Yes, and then you suture. So there's different types of suture. I have to just say whatever works in your hands. I use Vicryl, usually 5.0 or 6.0. But whatever works in your hands, whatever technique. You can even just do simple interrupted. It's just got to be good suturing, get the soft tissue in the correct place. Mattress sutures are good as well. And then if you need to, you put a dressing on. If it's restorative crown lengthening, you might want to use some Copac.
When you start taking on more complex restorative cases, or you start doing smile design cases, these kind of cases, you tend to appreciate that there are two other types of disciplines or two hard skills that really benefit a lot of these patients. Number one is orthodontics. Like a lot of my restorative patients, they would really benefit from pre-restorative orthodontics. And that makes sense, okay? With restorative, you can actually intrude teeth, get the gingival levels evened up. You can actually make your dentistry less invasive, less prep by getting the teeth in the right positions. But the second one is actually soft tissue related. More and more to get the gum lines even for what we call aesthetic crown lengthening. There is a huge role in the perio. So this episode is focusing on that. This is with Reena Wadia. Reena Wadia is someone who's really inspired me for so many years. And when I was a dent student, she qualified and she's always been a mentor to me. In fact, I've mentioned Reena's name in the previous episodes as, you know what, Reena taught me this or Reena taught me that. So she's such a great giving clinician. She's a specialist periodontist. I know you will love her. And today's episode is talking about just crown lengthening surgery, where it comes to aesthetic crown lengthening, i.e. doing some sort of surgery to make the gum lines, the gingival zeniths more even and presentable, or functional crown lengthening. This is when you're actually doing crown lengthening to allow you to get more of a ferrule, so you can actually restore a tooth. We're going to talk differences, how to plan for each one, what's a post-op advice to give, and many more gems. The protrusive dental pearl I have for you is how to find out what kind of biotype you're dealing with. And the classic way to do it is you use a ball-ended perio probe, and usually the perio probe has like a black ball, right? So it's like a black painted ball, and then you put it inside the sulcus, okay? And if you can see the black or the probe shining through the gingiva, then you know you've got someone with a thin biotype. And you write in your notes, okay, diagnosis, thin biotype. If you can't see the probe or if you can't see the ball end, then that is a thick biotype. And that's a good little technique that I learned, which is very relevant to this episode. We'll also be talking a bit later in this episode about how to do bone sounding, okay? What is bone sounding and how to do it and how it's relevant to your planning for crown lengthening surgery. So if you don't know what your altered passive eruption is to your altered active eruption, then this episode will sort you right out. Let's join Reena now in the main podcast and I'll catch you in the outro. Reena, your ears must be burning because I know you're super busy and stuff. You probably haven't had time to listen to a podcast like for commutes and stuff, but your ears must be burning because I talk about you now and again on the podcast. I say, you know what, Reena taught me this many years ago, or Reena once taught me this. So it is so nice, Reena Wadia, to have you on the podcast today. How are you?
Yes, really good. Thank you. Thanks for having me on the show. Congratulations on such a successful podcast and delighted to be here.
Thank you. It's down to the Protruserati. So those who listen to the podcast are called the Protruserati, and it's all down to them all over the world who listen. So it's really nice. And we're going to cover the theme of crown lengthening surgery. And you are someone who's taught me so much more than just perio stuff. Back in the day, you taught me about life. You taught me about communication skills. You taught me about how to navigate this difficult minefield of dentistry. So I'm sure some of those nuggets I might just say now and again, oh, Reena, remember that time you taught me this or whatever? So we might just take lots of different directions. But for those very few people out there who don't know who you are, Reena, just give us a quick little intro of yourself and what you do.
Sure. So I'm Reena. I'm a specialist periodontist. I'm based in London. So most of my week, I'm at the clinic at 75 Harley Street, where we've got a specialist clinic with me and a few hygienists as well, which I really love and enjoy. We recently moved to our new clinic, which has been exciting. And then once a week, I'm in the hospital as well at King's. And then the rest of the week, I'm teaching, doing podcasts like these and enjoying myself as well. So it's a really nice balance.
Do you still do your Instagram lives? I remember at one stage you were doing some loads and I used to enjoy catching them. Do you still get time for much of that?
I'm trying to keep that going. I think I had more time during the lockdown to do all that. But I think technology is amazing. I mean, things like this, things like Instagram Live, it's a great way to connect with people and share knowledge and information. So I'm hoping to do more of that going forward now that the practice has settled down.
You need to, because your presence on camera, your teaching ability is something I model. I like to go, how can I be more like Reena when I'm communicating something, because something I've admired for many years. But today we're going to really cover something really well, which is crown lengthening surgery, which we're going to start from the very basics, because over the last 6 months to a year or so, a lot more dental students have started to listen to the podcast from all over the world. So let's just even start with the very basics, like what is crown lengthening surgery?
Yeah, and actually don't underestimate the basics, because with things like crown lengthening, often if you don't get those basics, that's when things go wrong, which I'm sure we'll go into later. But it's always great to start off with a definition. So crown lengthening is basically what it says. And essentially it's removal of usually soft and hard tissue to gain supragingival crown height, basically. It usually involves removal of bone. Sometimes it doesn't. But essentially you're creating more tooth crown or structure above the gum line. And you're recreating usually what we call the biologic width, which is now called supracrestal tissue attachment, according to the new classification.
Wow, I had no idea, actually. This is news to me. So now it's called supracrestal tissue attachment. So no longer we're going to be using biological width.
Yeah, I do like the word biologic width, I have to say.
Yes.
I think I still kind of use it, but if you want to be perfect and textbook, according to the new classification, it's supracrestal tissue attachment.
Okay, fine, fair enough. Let's go with supracrestal tissue attachment. Now, I think for the basis of this podcast, that's not going to stick with me. So if I say biological width, I mean supracrestal tissue attachment. Okay, fine. Well, one of the most basic things that I got exposed to crown lengthening early on was when I saw some cases on social media, where else, right, where someone had just come and like on one side, like upper right canine to upper right central, they just started to use a blade to cut away tissue. And it looked amazing. I was like, wow, this right side revealing the true clinical crown of that tooth compared to where the tissue was overgrown on the left. It looked amazing, right? And then I thought, this is great, right? Let's go to Monday morning practice. And the biggest mistake someone could make now, and we're going to discuss this very, very much detail now, is you can just make a huge mistake by just cutting away the gum, and then that's it. It's not as simple as that, because you alluded to it already. You also need to consider hard tissue bone removal. So the most basic question, I think the most fundamental question everyone should be thinking is, okay, at what point can you get away with? Because I have in a few cases gotten away with it. When can you get away with just simple soft tissue removal? Maybe you're trying just improve the gingival zenith, which is the highest point of a tooth, of a central, just to match it before you do your crown. When can we get away with that? And then when can we not get away with that? And then we have to consider raising a flap, bone removal, sutures, blood, like the t-shirt I'm wearing, that kind of stuff.
So this is such a fundamental question. And I think if you don't understand the principles, this is where you'll get it wrong. And this is where, when you do it, it might look nice for like a week or two, and then the patient will come back and it's an absolute disaster. So it's all about the biologic width. So with crown lengthening, what you're trying to do is recreate the biologic width. Now, the biologic width is something very special, or I should call it supracrestal tissue attachment. You have to respect it. If you respect it, it will respect you. That's what I always say. So that biologic width, firstly, let's define what it is. So it's the junctional epithelium plus your connective tissue. And according to Garguello, which is a person who, kind of 1961, long time ago, defined it, it's 2 millimeters approximately. Now, practically, if you include the sulcus depth, we say it's sort of 3 millimeters. So the number for you to remember is 3 millimeters. Now, what you have to always check is, do you have that 3 millimeters? So when you're looking at your tissue margin, or whichever your reference point is, to the bone level, if you have the crestal bone level.
Can we make this really specific and tangible? So let's talk about the upper right central incisor and the upper left central incisor. Let's say that your the upper left one is just more gummy, right? And you want to now check with the upper left one. How would you do it?
Right. So you'd firstly find your reference point, which is going to be the same as the other one, right? So you want to match it. So if from that point to the alveolar crest, you've got 3 millimeters, guess what? Great, you've got your biologic width. You don't need to worry. If you don't have 3 millimeters between your reference point and your bone, you will need to recreate it, which is normally the case. And if you need to recreate it, you recreate it by removing bone so you can shift that space up. So the point is, if you're probing or you've got a radiograph and your bone's sounding and you've actually got 3 millimeters once you've cut the gum, right? You've cut the gum to where you want it, then you've got 3 millimeters till the alveolar crest, you're fine, great. You've already got your biologic width or your supracrestal tissue attachment. If you don't, you then need to raise a flap and remove bone so that you then create that 3 millimeters. Does that make sense?
Makes perfect sense, and please don't try this at home unless you've actually done a course or something like that, and we'll talk about that at the end. But, right, you mentioned bone sounding. Please explain what is bone sounding and how to do it. Like, I'm familiar with it, I've done it, but maybe based on your description, I might realize, hey, maybe I've done it wrong a few times. So what is the best way to do bone sounding? So you've got the central incisor, you want to check, is my bone 3 millimeters away or not? That's called bone sounding, but tell us how to do it.
Yeah, so bone sounding is an interesting one. It's a way of determining where the bone level is, so you know if you need to remove bone or not, and you know if you need to raise a flap. Now, there's other ways also of determining where the bone level is, like your radiographs, or like actually just raising a flap anyway and seeing where the bone is. That's the safest way of doing it. But bone sounding is a technique which you can use during your planning phase to get a bit more of an idea of this. And what you do is literally what it says. You could usually numb the patient up if you're nice, and then you literally get a probe and you just push right down until you feel the bone. So it's quite not like normal probing, right down. And when you feel that hard bone, that's where you measure and you say, okay, that's where my bone level is. So that's bone sounding. I have to say, I don't often bone sound. My kind of technique is I pretty much always raise a flap unless it's extremely obvious that you don't need to remove bone, because you don't really know until you physically see the bone exactly what this, not just where the bone level is, but the structure of the bone. Because sometimes with crown lengthening, you've got this bulbous bone, right? And you want to actually recontour the bone as well. It's not just about ostectomy, it's about osteoplasty as well. So there are many benefits of raising a flap. So I always advocate, usually, unless it's super obvious that you don't need to, being safer, doing it properly the first time rather than making your patient go through surgery again if it doesn't work.
I think within your remit as a specialist periodontist, I think, you're so comfortable with raising flaps, so that makes sense how you do that. And then you can control all the outcomes. Like you said, a real pearl you gave that is that sometimes periodontists, when they're doing the surgery, they have to remove the thickness of bone as well, which is something that people don't appreciate sometimes. So that's a really good tip there as well. With the bone sounding, like me as more of a restorative background, I'm more likely to do bone sounding than number of the flaps I will raise in a year is way less than you. So I am doing more bone sounding. That one thing that I might want to say, and you correct me if I'm wrong, is sometimes when you're starting bone sounding, you go in and you think you're there, but you're probably just at the connective tissue. You actually need to just really go a little bit more, and then you hit the bone. Is that something that you might find a beginner might make a mistake like that?
Definitely. Don't be too gentle. And they're numb, so it's not going to hurt. So definitely you're going to be a little bit aggressive with it.
Okay, so let's talk about the difference between, from what I know, there's two types of crown lengthening. There might be more, but as a general dentist, there's aesthetic crown lengthening and functional crown lengthening. Is there any more? And then can you just go over a little bit about each one, the differences?
Yeah, so you're right. So there's two major types of crown lengthening, aesthetic and restorative. Aesthetic is becoming more and more popular, I have to say. Getting lots of patients interested in what they call the gum lift, which I find really funny. Or I like to call it gum. I think there's a bit more than a gum lift. I quite like gum sculpting more than anything. But anyway, aesthetic lengthening is getting more popular, and it's a great skill to have as a general dentist as well, because if you're doing all these beautiful smile cases, it just adds that extra bit to it at the end. And I think you can't forget about soft tissues. The pink part is really important. If you put all that work into doing Invisalign and all the other bonding and whitening and everything else, if your gingival margin isn't quite right, it's going to affect the final result. So aesthetic crown lengthening is what it says essentially is to improve the aesthetic. So it could be, for example, like you described earlier, uneven gingival contours, right? So one is slightly higher than the other, and that slight difference can make every difference to the smile. So small but significant impact. Other ones, sometimes just generally gummy smiles, conditions such as altered passive eruption can cause...
I totally want to talk about that. So if we can just go into what that means. Like when I first came across that, like 2 years out of dental school, it would just completely confuse me. Now I've got some clarity on it, but I think this would be such a fundamental thing to cover. Yeah.
So do you want me to talk about that now in terms of autopass eruption?
Yeah, let's do that.
Yeah, sure. So autopass eruption, so this is quite surprisingly, a lot of people don't know about it, and it's one of the most common reasons for a gummy smile. And I have to admit, I actually didn't know about it until I did my specialist training. So it's not something that's really touched upon or usually at undergraduate dental school. So going back to basics, basically you have active eruption, which is when the teeth come out of the jaw, essentially, in the most simplistic terms. And passive eruption is when your gingivae retract around the tooth. And it's 4 stages. I won't bore you with the details, but there's 4 stages as to how the gingivae retract. And that's passive eruption. So active eruption, passive eruption. Altered passive eruption is when that process doesn't go quite to plan. And when the gingivae doesn't quite retract to the level of the CEJ where it should be. So what happens is your gingival margin is coronal to your CEJ, and biology hasn't quite finished its job. So with crown lengthening, what you're doing is almost recreating where the gingival margin should be. So the CEJ is underneath the gingival margin. And there's different types of altered passive eruption. You get 4 types, 1A, 1B, 2A and 2B. And if you look at the classification, it depends on where the bone level is and the amount of keratinized tissue that you have, attached gingivae that you have as well. So you can then divide it up. But I think it's extremely common. The incidence is like 11-12%. So it's not uncommon. And you might find that most of the cases that you see that are gummy smiles are actually altered passive eruption cases.
Reena, because it's altered passive eruption, so no one's ever explained to me like active eruption, passive eruption before, so I love that. So with the altered passive eruption, because it really helps you to explain it, because it's the passive part that's had an issue and not the active part, so is active more like bone and passive more like gum, right?
Yeah, but active is the tooth and the bone, and then exactly. The passive eruption is the gingival part of it, essentially.
So does that mean that someone who's got altered passive eruption might be someone who gets away more with just the gingivectomy without the bone removal, or is that not the case?
No, so I would probably say that the passive side, I just focus on gums, and I would actually say periodontium structure. So the bone in passive eruption might be at the right level, it might not be. So there's 2 different types, and in one type it is at the right level, one type it isn't. So depending on what type it is, so if it's, so you have, I'll just go through it. 1A is basically osseous crest is apical to the CEJ, and then 1B is osseous crest is at the CEJ. So for 1A, you would do a gingivectomy, whereas for 1B, you would do a gingivectomy plus osseous surgery. So active eruption, I would say, is the teeth, and then passive eruption is gums and periodontium, basically. I was just going to say, it's just good to know about it, because personally, I think if before doing any type of treatment, you need a diagnosis as to why you're doing that treatment. It's just important to highlight that you do need a diagnosis before you then do treatment, i.e. crown lengthening. So knowing about altered passive eruption, that could be your diagnosis, or a fractured crown might be your diagnosis, but you need to know, you have to have a diagnosis before you prescribe treatment. So I think it is important to know about its condition.
Great, and we were just touching on the difference between aesthetic crown lengthening, which how APE tied in so nicely with, but then now can you just touch a little bit on functional crown lengthening and when we might do that, and which is the most common tooth that you get referred for functional crown lengthening?
So functional crown lengthening, also called restorative crown lengthening, is basically when you have inadequate tooth structure. It's a strategic tooth, you're trying to save it, but you just don't have that 2mm ferrule. And by doing restorative crown lengthening, you're essentially creating that so you can restore the tooth. It could be that you've got a fracture, you've got a perforation, endoperforation in the coronal third. That's key. You're not going to do it if it's like in the apical third. So something in the coronal third, and you're trying to save that tooth. Or an important point is, if you're trying to relocate the crown margin when it's been impinged, i.e. someone's not respected the biologic width, guess what? You're now going to have to do crown lengthening to recreate it. So that's actually really common. I'm seeing it more and more.
I mean, the most common time I say the most common, the few times I've done it, I have done it to get more ferrule so that I can now make a tooth that was previously unrestorable, more restorable, give it a better prognosis. Which is the most common tooth that you get referred for this?
It's usually a lower molar. From my experience, that's what I've had so far. It's usually like a strategic tooth. They've already lost another molar behind it. Patients are really keen to save it and do everything they can. And don't want to jump straight into implants, and that's usually the most common thing. And I always say to the patient, everything has a lifespan in dentistry, and so if you're going to jump to an implant, guess what? That implant also might have a lifespan. So the longer you can keep your own tooth, the better. And I'm not saying to do heroics, like if it's, a tooth which is completely broken down, has got like a 10 millimeter peri pocket, terrible endo. Yes, it may be better to extract that. You have to be sensible, but usually nothing's better than your own tooth in my experience.
Fantastic. Because what people really resonate with, what dentists really resonate with when they listen to podcasts is there's little sayings, there's ways that we communicate with patients. So that's awesome. So yeah, you said lower molars are the most common that you found, and I can see the rationale behind that. And I love what you say to the patients. Now, what is a fundamental difference between the aesthetic crown lengthening and the restorative crown lengthening in terms of the surgeon when you're doing the procedure?
Yeah, so in terms of the differences between the two, firstly, the similarities is that the principles are the same. So you're in both scenarios, you're trying to recreate the biologic width, and you're using a reference point. Now, the differences are the reference points. So usually for aesthetic crown lengthening, it's usually your CEJ, especially in ultrapassive eruption cases. Whereas for restorative crown lengthening or functional crown lengthening, it might be, a certain crown margin. It might be that amount of sound tooth tissue that you need. So it varies. The actual technique itself, again, the principles are the same, i.e. we'll go into this a little bit more detail, but you remove the gum, raise the flap, remove the bone, stitch it back up. However, for aesthetic crown lengthening, usually it's just buckle, because it's you don't see the palatal or lingual, so it's usually just buckle, whereas for restorative it usually is 360 across the tooth. For restorative crown lengthening, usually if it's at the back of the mouth especially, I wouldn't be worried about doing vertical releasing incisions, not that bothered about it, whereas anteriorly I really would avoid it because you don't want any scarring, because you're doing it for aesthetic reasons. So we try to minimize, and usually you don't need it, to be honest, for aesthetic use. Sometimes it's usually a kind of 4-4 case or 3-3. You've got enough access without doing a relieving incision. Often as well your end goal is also different between the two while you're actually doing it. But often for aesthetic crown lengthening, I would also consent them for what I call a revision surgery. Because when we go to the restorative phase, often these patients, they want a little tweak before the final restorations to make everything perfect. Or if you get gingivae overgrow again, then you might need to do a bit more surgery. So that's less important for restorative cases. So I would consent for revision surgery for aesthetic crown lengthening as well. And I guess the other difference is with the healing, I often use things like Copac for restorative crown lengthening because it really keeps the tissues down, whereas for aesthetic I would not be putting Copac at the front of the mouth. Copac, just to explain, is a dressing that you can use, periodontal dressing. It looks a bit like pink chewing gum, feels like chewing gum, and you just press it on the tissues and it essentially just keeps the tissues in place, and then 2 weeks later you remove it and take the stitches out. It works beautifully, but it's not something that you're going to paste across someone's front of their mouth. So
anterior cases, those aesthetic ones, we just you're not using a Copac, but you're just letting nature do its job.
Yeah, you need to suture. You always need to suture. If you raise a flap, you have to suture. But apart from that, yeah, the gums will just heal. And suturing is really important. I mean, everyone focuses on the first few stages of removing the gum and bone, but your sutures is where your tissue is going to end up, right? So spend time on suturing as well and doing it well.
Amazing. So good few pause there. I'm going to go really geeky now and ask you a geeky question, which always bothered me about this subject, right? And I just can't get my head around it. So now that I have you on the show, I'm going to be very selfish and ask a question, but I'm hoping it'll help others who are thinking the same thing, right? So you mentioned about the similarity between aesthetic crown lengthening and restorative crown lengthening, i.e. you have to cut some gum away, you raise a flap, you remove the bone, etc. You suture back, which is so important. Now, that scenario where you actually cut the gum away, okay, let's just talk simplistic terms, right? The gingivectomy, you cut the gum away, and yes, you got different goals, the CEJ being one and the other one just revealing more tooth structure, but everyone's got a defined and finite amount of keratinized tissue, right? So let's say, you've got some patients, right? And they've got like miles of keratinized tissue, like thick, meaty, I'd love to do crown lengthening on a case like that. But then you've got someone who's just got 2 millimeters of keratinized tissue, right? So what if for that patient who you're doing, let's say, a restorative crown lengthening on the lower molar, they've got, let's say, 4 millimeters of keratinized tissue, and then you cut away 3 millimeters, and then you do your crown lengthening, and then you suture it back. What happens, right? Does it just stay as 1 millimeter keratinized tissue for the rest of that patient's life? Or does the apical part of it suddenly become keratinized? What happens? What's the biology of that?
Yeah, that's a really good question. So I think the first important point is keratinized tissue is important. It helps patients to comfortably clean around the gingiva, so it maintains health. So keratinized tissue, if it's there's not tons of it, you need to be careful, basically. So in most cases, you'll have enough to be able to do a gingivectomy, raise a flap, remove bone, stitch it back up. But in the rare cases where you don't have sufficient keratinized tissue, and you know by then cutting it away, essentially there's going to be hardly anything left, you need to change your technique. So in this case, you actually need to preserve the keratinized tissue. You need to raise the flap right past the mucogingival junction, and actually, after you've removed the bone, apically reposition the flap. So it's a different technique for those types of cases. I have to be honest, I can't remember the last time I did that. So in most cases, you will have sufficient keratinized tissue, but you are right, you need to be on red alert if that happens. Preserve the keratinized tissue. And I'm biased as a periodontist saying that, but honestly, it is really, really important to have it there.
So essentially, that's the difference then, therefore, between what we call resective crown lengthening surgery versus, is it apically positioned? Is that the correct term?
Correct, yeah, apically positioned, yeah, using a different approach, exactly.
Fine, that's the one I've never done, an apically repositioned. Is that something you teach on your course?
It is, yeah, it is something that I teach, but it's so rare that you probably won't need to, you need to do it. If you were starting off for the first time, I wouldn't advise that as your first case. You want one with stacks of keratinized tissue, as you said. So it's more tricky for sure.
Okay, so Reena, we've taken like a little geeky detour covering, all the wonderful things that you answered. My fault, because I asked you geeky questions about altered active eruption stuff. But really, I want to hear, because I think what people find useful in this podcast is hearing the steps, the little steps. And what you taught me many years ago, Reena, was micro steps. You taught me the term micro steps out. And this is the difference between success and failure. It's not the big steps, it's those little micro steps you take. So within the remit of the podcast episode, let's cover a couple of minutes of what are the steps involved in crown lengthening surgery.
Yeah, micro steps, it's so important. Honestly, some of the best clinicians, it's not just about the macro steps, it's about the tiny detail and doing it consistently every single time. So it's good you remember that. So the first step I would say is assessment, to plan your approach. And it's all about planning. Crown lengthening, the actual procedure, the surgical side of things, is actually not that difficult. It's the planning stage, as with anything in dentistry. So you've got to plan a couple of things. So firstly, you need to look at your periodontal health. And I know I'm biased, but I've seen too many cases where someone's got periodontitis and they start hacking away and doing aesthetic crown lengthening. It's not appropriate. Cutting tissues that are inflamed and there's plaque everywhere, it's going to be messy, it's not going to heal well, you could make it worse. So step by step, get the periodontal health super healthy. Patient plaque control needs to be optimal. Look at other restorative factors. Do you need to redo the endo? Is there anything else you need to do restoratively before you then start your crown lengthening? Also determine your reference point. What is your reference point? Is it the CEJ? What is it? Because that's going to be what you're going to be measuring from, and you're going to remember that 3mm rule, essentially. If you're doing aesthetic crown lengthening, you need to plan your gingival aesthetics. So, know the gold standards. Where's that zenith meant to be on the canine? Where's that zenith meant to be on the central? Is it meant to match, et cetera, et cetera? So you need to plan that out. I quite like what I've started doing now. I have my iPad, and then I import the patient's photo, and I've got a little pen, and I draw on, and then I show that to the patient as well. It's an
you're
element
so
of
posh,
consent.
Reena.
I know. I used to use paper and draw it on, and I thought I better up my game. So I'm using an iPad with me. It's quite fun. So quite therapeutic. And then also looking at the amount of keratinized tissue that we discussed as well earlier, and also where your bone level is. So they're all your kind of key components when you're planning your case. The next thing is then your flap design and your incisions. Give yourself more room than you might think, especially with restorative crown lengthening. Don't be too conservative. You've got to go one tooth either side of the tooth you're treating to get enough access to the bone. So flap design, incisions, if you're doing aesthetic crown lengthening, I teach certain flap designs where you're not going through you're not actually raising a papilla, because you don't want to risk having black triangles. So there's all these little nitty gritty things to be aware of. We then remove the excess gingival tissue and you raise your flap. And throughout all of this, you've got to have the right instruments. Don't underestimate, as with anything in dentistry, good quality surgical instruments are critical. It's all about microsurgical now as well. So I've got, a nice set of microsurgical instruments. Perio is very delicate. It's not like oral surgery. You've got to be very detailed and delicate. It's a completely different approach, which applies to crown lengthening as well. Anyway, as I was saying, you raise the flap and then you see where the bone is and you do your osseous management. So at this point, you remove the bone, whether that's using a slow handpiece with water and a round burr. I've started using a piezo as well. You can actually get a piezo which removes bone, which is quite nice. So I've been using that. Once you've got your bone levels sorted, you then suture.
I'm just going to stop you there, Reena, because you talked about the bone removal and you talked about suture, but I've seen before when I was at Guy's doing my DCT post that sometimes you get these like Essex retainers, like little stents made to guide you. Do you use those?
Yeah, I used to quite a lot, and depends on who I'm working with. Often the cases are referred by dentists who've, gone to the effort of making a wax up, sending a stent. It can be helpful to give you a general idea. And there's different stents. Some stents just show you where to cut the gum, essentially. You still need to use your own clinical skills to make sure you get it perfect, but it gives you a guide. It's a guide. Some stents are very sophisticated. It also shows you where to move the bone up to. So it depends. I think if you're starting off, it's worth doing.
Well, I'm trying to envision like doing a bigger case, and because you're so experienced in this now, is like imagine you've done your gingivectomy, you raise the flap, you remove the bone, but then because the gum now behaves differently, once you raise the flap, it becomes flappy, right? So when you're trying to like approximate it back to kind of measure, okay, will it look okay? Any advice on eyeballing that?
Yeah, the stent can be useful in that case. What I'm generally doing is quite simple. You just put the flap back, push your elevator against the flap, and put your probe underneath, and you just keep doing that, basically. And that's how I generally do it. So,
okay.
Which works quite well. Yes, and then you suture. So there's different types of suture. I have to just say whatever works in your hands. I use Vicryl, usually 5.0 or 6.0. But whatever works in your hands, whatever technique. You can even just do simple interrupteds. It's just got to be good suturing, get the soft tissue in the correct place. Mattress sutures are good as well. And then if you need to, you put a dressing on. If it's restorative crown lengthening, you might want to use some Copac, and then you let everything heal. And usually it's 2 weeks then you review them, remove the stitches. I usually get a cotton pledget, dip it in Cortidil. I don't like using the C word. That's the only time I like using Cortidil is after surgery, where I literally wipe the gingivae and remove the sutures. And then you just let it heal. And I guess timing wise, in terms of cases, you're looking at, for restorative cases, you need to wait 3 months prior to putting your definitive restoration on. You can put your provisional. After sutures out, you can go straight to provisional, but you need to wait ideally 3 months. For aesthetic cases, the textbook answer, you actually have to wait 6 months. I have to say, some of me and my referrers, we wait 4 or 5 months and we're usually okay. But what you need to be aware of is the gingival margin can continue to slightly change up to 6 months. So if you want to do it properly, get some good provisionals on, possibly lab-made provisionals. Just let them be essentially for 6 months. Once everything's perfect, then go into your final ones. Because the last thing you want is you've got your finals in, and then like a month later, gingivae ever so slightly goes higher or lower, and then the patient's not happy and you have to redo everything. So that's your kind of overall step. So you assess flap design, incisions, raise the flap, remove the excess gingival tissue first, raise the flap, remove the bone, stitch up, let it heal, and then move on to your restorative phase if there is one.
If you're doing any revision surgery, then does that reset the clock for 6 months?
Usually not, depending on what it is. If it's it's usually the tiniest amount, so I think it doesn't really count. Unless it's extensive, then yes, reset the clock, unfortunately.
Gotcha. So you've done your crown lengthening surgery with those lovely steps that you talked through. What's the post-op care looking like for a patient? Now, you mentioned about how long to wait for restorative, which is one of my next questions. That's awesome. So we know that. 6 months for aesthetic cases, perfect. But post-op wise, what do you say to the patient?
Yeah, so in terms of, for any surgical procedure, they're going to be on chlorhexidine usually for 2 weeks. No brushing of the area because it's technically a wound. So if you can't brush it, it's a delicate area. Brushing the rest of the mouth as normal. Soft foods, ideally for as long as possible, but ideally a week or so. Just be sensible, nothing with like seeds and crusty things that's going to affect the healing. And then just in terms of 2 weeks after, once you've removed the stitches, they then can start brushing the area. And crown lengthening is unique in the fact that unlike other periodontal surgeries, you can start brushing quite quickly, and you kind of need to, so the gum doesn't try to go back to where it was. So with other types of periodontal surgery, sometimes for months they don't brush. So it's quite different with crown lengthening. So, and of course, after any surgical procedure, patients need to take it easy. No major exercise, anything like that. Painkillers, regular painkillers are fine. I also include an ice pack that they can just put on their face, especially if you're doing a big case. key thing is give them everything they need. The last thing you want is you put your patient through a massive surgery and then they have to go to like Boots to buy all this stuff on the way home. It's not fun. So give them a goodie bag with everything they need: ice pack, painkillers, straws, whatever else they need, mouthwash, gauze, so they're ready, to go straight home. I think that preparation side is really important. I also send them an email the week before telling them how to prepare. So get your foods ready, soft foods, food replacement drinks like Huel, really good, all those kind of things. Get them ready, painkillers, all of that, so they feel prepared. Otherwise, they're just, they don't feel prepared and they get more anxious and everything goes wrong. You need a calm patient if you're doing these types of cases.
That was brilliant. I really love the Huel reference, which is I never thought of that, but I guess that's something new, right? We can start having these meal replacements. It makes so much sense. And also having a goodie bag. You're so right. You made it really clear that you don't want this patient who's just had this surgery, numb lips, to go to Boots to buy something. You're so right. We should totally make a goodie bag. Last question, last couple of questions which are clinically orientated. I want to ask about which is the ideal case. Like imagine, so this is something you teach. What do you tell your students, right? Okay, when you go out Monday morning, find a case which ticks these boxes.
Yeah. So when you're starting off, I would say a restorative crown lengthening one is good as a first case because it's the back of the mouth. Something goes not wrong, but it's not beautiful. It's not going to be the end of the world. Lots of keratinized tissue, possibly minimal bone removal. So you just get practice of raising a flap and doing some minimal bone removal. Once you've got the hang of that, then you can move on to a bit more complex and possibly anterior cases with lots of keratinized tissue, but again, minimal bone removal. So start off easy, get your confidence, because the last thing you want is you do a case and it goes wrong and you know what it's like, right? You just don't want to do any more. So you've got to have an easy first case.
Pick someone with a very low lip line and you do aesthetic crown lengthening on them. That's the best person. Which I don't see the point of, but hey ho. You see it done on the gram sometimes.
Yeah, and a nice easy patient, like not one that's like ridiculously nervous and difficult, if you see what I mean. So, fidgety, yeah.
Excellent. Geeky little tiny questions now. Sutures, facing buccal or facing palatal? Let's say you're doing some upper crown lengthening aesthetic. So they're not facing buccal or they're not facing palatal, or does it not matter?
It probably doesn't matter too much. I always do buccal. I think it irritates them more when it's palatally on their tongue and they keep playing around with it. So I stick to buccal knots. Okay,
sweet. And then always the cold blade, or is there a place for laser?
I absolutely I'm very traditional. I love the blade. But there is a place for laser. I have to say I don't use it. But if you're doing simple gingivectomy cases, you can use a laser, and it's great because it stops the bleeding as well. So if you're doing an overgrowth case, is actually technically, if you're removing the bulk, that is a type. I should have said actually that's a type of crown lengthening. Technically, if you want to be geeky, which you are, and I am as well. So that is a type of crown lengthening. And for those type of cases where you get a lot of bleeding, the laser might be really useful.
Are you talking like those amlodipine-induced gingival?
Yeah. Technically, fine. If you're removing that bulk, you're actually crown lengthening. Mm-hmm. So that is technically the third type. But anyway, I mean, it's whatever works in your hands. I think at this stage, it's worth possibly starting off with a blade because it's kind of traditional thing to use, and then exploring other systems. And one thing I would say is don't complicate things. Like if something works in your hands and you're doing it well, keep things simple. Don't have too many variations in what I call your micro steps or building blocks, because then things start getting unpredictable. So test everything out, go on courses, and then see what works in your hands, and then stick with that.
Well, that leads me nicely to, because I've seen so many good reviews on your course with video testimonials. Your videos that you've made have been so crisp. Tell us about, I mean, is it purely online? There's a hands-on as well? I mean, how does that work with your course?
Yeah, so all of our courses are under Perio School, which I set up during the lockdown, which is really exciting. And originally Perio School was all online because it happened because of the lockdown. So I had to cancel all my courses, basically made everything online, which has been amazing because people from all over the world have been accessed. It's got a massive community now, which is really exciting. So there's lots of courses online. The crown lengthening one is hands-on because there's no way I think you can just learn it from watching a video. You need to come in person. We've got special models that we ordered from the US where you can remove the gum. It's very cool. We've got pig's heads, obviously, to get the experience of removing gum, bone, stitching, all those kind of things. And so the key crown lengthening course is the hands-on course. It's a one-day course, usually on a Sunday. So oh,
nice. You're such a geek. I love that.
Everyone loves it because it's, you don't normally have to give up a day of work, which is nice. The next one's on the 18th of July. And if you go to www.perio.school,
And that's on a Sunday? That was a Sunday, right?
Yeah, that's a Sunday.
Oh my goodness, that sounds so enticing. Okay, I will definitely take a look at that. So is that one just purely hands-on? Is that an online component as well?
It's purely hands-on, and we literally go step by step. I mean, we've had like new grads on that, and it's for anyone really. We've had like people with 20 years experience, people who've just qualified. And what we do, there's a lecture component, and I show you the bit, and then you do it. I basically explain it, then I show you, and then you do it on the pig's head. So it's step by step, and at the end of the day, you should be quite confident being able to go. My whole point is you go out into practice and you can actually do a crown lengthening case. That's the whole point. I have to say as well, though, there is mentoring after that as well.
I was just going to ask about that. Do you have like a secret group or something that you can post to?
Yeah, no, it's just one-to-one. So basically, whenever you get a case, we'll talk through it. We'll do a quick video call. We'll talk through the steps. Then we'll talk about how it went after. You can take some pictures. It's just till you get the confidence, because the whole point, of course, is for me is the satisfaction for me is for me to you be able to say to me, Reena, I've gone out and done my first case, and then it's like, yeah, I don't want you to say, oh, that was a good course, and then that's it. You want to be able to apply it. So yeah, it would be great to have anyone who's interested on there. And if you've got any questions, just get in touch.
I will definitely put the link on the website ASAP. So guys, check that out on a Sunday. That sounds amazing in London. And I totally echo what you said about try and get delegates to do their first case ASAP and supporting them. It's the same with the splint course, which I set up. And I just love our little community. And every time someone posts a splint that they've done and they color it in and they do a parafunctional analysis and stuff, it makes me so happy. And then now everyone's taking videos of their patients saying, you know what, my headaches are gone or whatever. So same with you, I guess, when patients send you, when dentists send you photos of their patients who they're in crown lengthening surgery, you must feel so proud and have that warm, fuzzy feeling inside.
It's amazing. It's very makes me really happy. But also in the patients, when you hear that, as you said, their reviews, things like crown lengthening can be life-changing. Don't underestimate the value of it. Whether it's aesthetic or even restorative, you manage to save someone's tooth. The value of a tooth is huge. So if you can have this skill, which I think is great for anyone in practice, whatever specialty you're in, whether you're general practice or, it's literally a key skill for everyone. So it's worth knowing about.
Sweet. Well, we're recording right now. It's June, and do you have any spaces available for July so I can message my community? Yes, we do. We've got around 6 spaces left. So it's going to be a small group of 10. So we've got a couple more spaces. So perfect. Yeah. Brilliant. I'll get that out to everyone. I'm sure we'll see some protrusive on there. Reena, thank you so much for covering crown lengthening in such a great way. It's always nice connecting with you. It's lovely to see you again after a long while. And thank you for giving up your time. Really appreciate it. No, thank you so much. It's been a pleasure. Well, there we are, protrusive. I hope you enjoyed that episode, Reena, all about crown lengthening. I hope you're now able to assess your patients better and look at them with a different lens in terms of when you see someone with short clinical crowns, they've got small teeth. Well, is it really that they have small teeth, or is it that their gum never matured? Okay, so it's a different way to look at someone, and then from there, when you make that diagnosis, some patients may actually desire, once you communicate the value of it to them, an aesthetic improvement in terms of crown lengthening, or you may plan some functional crown lengthening to help improve your restorative prognosis. So I hope you enjoy that very much, and I'll catch you in the next episode. As usual, please do check us out on Instagram, and of course our Telegram, our special little family on Telegram is protrusive.co.uk/Telegram to join our Telegram group, Protrusive only. I'll catch you in the next episode, same time, same place.